Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Hi everybody, welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So now we're going to do Best of ESMO :2, I think.
2025.
2025. But before we start, I need to ask you an icebreaker, which is if you're worried about flight cancellations, I mean, you told me something very interesting about this recently. What's your strategy to avoid flight cancellations? If it's not proprietary, your strategy, and you don't want to, you don't want to risk sharing it with other people.
I'll share. What a dorky quickfire, though. Sorry that you're so ill prepared with these quickfires that you ask really lame questions. So as we're recording this, we are in the middle of government shutdown in the US. And so that is impacting travel and all sorts of things. But what I've known for a long time, if you can fly the airport's hub airline, that's one trick. The other is try to fly a big aircraft. So a 777, a 787, if you can. The 777s have about probably 300 passengers on board, 380. 787 might have about 300. And then all the regional jets that are going to be 180 or less, those are the ones that they're going to more likely cancel than a 400 passenger flight.
You're from the US, and do you only have Boeing specification recommendations? Do you do any Airbus recommendations for the rest of us?
So there is, United has a few Airbuses. They have like an Airbus Neo, I think. But anyway, you get it. Look at capacity. Don't worry about the model. Look at capacity of the plane. So the bigger, the better. And because it's just a lot of work for them to rebook 400 passengers than 180, right? That's a little science of the obvious. And then the other thing is whenever I'm going outbound to Europe, for example, I try to make the first leg the international leg, because they're also incredibly motivated to let those go, keep those on time, very less likely to be canceled. But in general, if the first leg is overseas, you're likely to not be canceled. You might run the risk of missing your connection, of course, but I always give myself 3-hour connections overseas, as opposed to doing domestic, and then international. So that's one thing. And there was some other point to that I was going to make. Oh, I also just feel like if I get in Europe and then I miss my connection or something like that, well, I'm in Europe and then there's a train or there's, other possibilities to get to wherever. I don't know.
Wow. Okay. Wow. I mean, I think that segment alone could be our most ever listened to segment.
Okay. I feel like we're going to cut that quickfires. That was so stupid. Do you have any travel tips?
No, not really. Sleep whenever you can, eat whenever you can, that kind of thing.
But booking tips?
No, not really. Oh, no, nothing interesting, I don't think.
Because you don't even do your own booking, let's be honest.
Try and avoid it if I can, if I'm perfectly honest. Yeah.
Very hands-on with my booking.
Yeah, well, that's probably a good tip as well, actually. But maybe not labour that one. All right, so you've already told me what order we're going to do this in. And you wanted to do IO Biotech phase 3 first, is that right? And you definitely know more about this than I do.
No, that's not fair. I just talked the entire last podcast. This is you.
No, you do this one. And then I can talk about Checkmate 238 and Stopgap. That's fair.
Okay, so IO Biotech. This is the IO 102, IO 103 cancer vaccine plus Pembro versus pembrolizumab study, phase 3 trial. Just by way of background, they had some earlier data from a phase 1/2 trial. It was 30 patients. I think it was primarily done in Scandinavia. This was PD-1 naive melanoma. And when they combined their IDO PD-L1 vaccine with Nivo, they had a really striking response rate. It might have been in the 80s or so, 80%. So on the basis of that 30 patients, again, primarily in Scandinavia, they opened a global study of a few hundred patients. You'll have to keep me honest here. Ultimately, they ended up enrolling some 500 patients or so, randomized 1-to-1 to either frontline pembrolizumab, frontline metastatic setting pembrolizumab, or the vaccine that they use, IO-102, IO-103. This is an IDO PD-L1 vaccine plus pembrolizumab.
Just over 400.
400 patients.
About
Okay.
200 in each arm, yeah.
Oh yeah, 407, there it is. And this was a global study, so it was done in, parts of Africa, Turkey, other parts of Europe, a very small amount in the US, maybe one center in the US. I'm not sure about Australia. I'm not sure about the UK. You can tell me if you know, but and then their primary endpoint was progression-free survival. So they were going for an improvement in progression-free survival in the combination arm, and they missed it. Their hazard ratio was 0.77, the upper bound 1.0, so confidence interval 0.58 to 1.0, and the log rank p-value here is 0.0558. Their significance threshold was 0.045 because they spent 0.005 of their alpha doing an interim analysis, and the interim analysis, I'm forgetting what it was. It might have been objective response rate. And then when they looked, so they spent a little of their alpha, that's all to say. So their PFS, missed a little bit here. Maybe I'll pause there. I have some thoughts about subgroup analysis, but what do you think?
Yeah, I mean, that was going to be, it's quite a small randomized trial, at least in some ways. I think that would be one thing to say. And I actually I don't know if you've got this open in front of you, but I've got the slide with the PFS subgroups, the waterfall plot and the red bars. I don't know if you can see that. If you put it in presentation mode, the red bars are coming up.
Is there a waterfall plot somewhere?
Yeah. Is that not on? No, sorry, forest plot. Apologies. That's me. I've been on holiday. Bad excuse, really, isn't it? Whatever slide that is. Anyway,
I got it.
Yeah. Anyway, so the red bars are BRAF mutant, PD-L1 negative, high LDH, and then no prior treatment with anti-PD-1. So, I guess to be cynical about this, it's a small study, etc., etc. Are they not just pulling out the things where you're getting a differentiation? Or do you think mechanistically that these might be reasonable places to say, well, actually, maybe there's a signal here? And if so, does the study then need to be redone or not? That's a load of ridiculous questions, but I'm asking you anyway.
Yeah, I'm happy to give you a load of ridiculous answers. Yeah, they are pulling out small subgroups here. I don't fault them for trying to find the signal. I'm having a little bit of difficulty just sort of biologically understanding why the high LDH group would be the one that benefits. And then it was just a really small numbers of the study, Also, when I look at this, so only about 140 patients had high LDH of a 400 patient study. Okay, is that a numbers problem or is that a real signal? I don't know. PD-L1 negative, I can understand, but also it's a small portion of this population. People may wonder, how does a PD-L1 vaccine work on a PD-L1 negative tumor? But it does. It's not about surface expression. That's not how these vaccines work. And then no prior treatment, sure, that's going to be, and that is the majority of their patients. That might be a real signal to really try to clean up there, which is no prior adjuvant, no prior exposure to anti-PD-1 therapy. It is going to get harder and harder to find that patient population in the front line, but they exist. So there is probably, in my mind, a way. The signal looked real in the phase 1, phase 2, but it then got watered down by some of these other subgroups, I think. So I think there is probably a way to redo this should the funding hold. And I think there's enough interest in this molecule and the mechanism by which it can help with melanoma and perhaps even other tumors. I do think it might be worth redoing this, kind of doing a deeper dive in some of these subgroups. I'm not clear on the BRAF situation, though.
Yeah, I mean, I've just got the final slide up here as well, key findings and conclusions. And so the top line fairly prominently quotes a difference between median PFS of 19 months versus 11 months. And I think you kind of know my thoughts on that kind of top line already.
Right. Is your thought that numerically that looks nice? It's just a bummer it didn't hit statistical, or no?
Well, it's definitely a bummer it didn't hit statistical significance, but I just think quoting median PFS differences when the lines are sort of, fairly flat, as it were, and actually it's a non-statistically significant hazard ratio. I just think that actually could be misleading overall if you just read that and said, oh, look at that, what a major difference.
Basically, if you made the comment that I made to start, which is, oh, look at that, could be right. But you're right, median would be, yeah.
And then the third bullet point here, I mean, we haven't talked about tox, but I don't think there's anything really to say there, actually, out of the ordinary. Just we'll say that for completeness. But the third bullet point, profound effect, I'm reading, in the subgroup of PD-L1 negative tumours. And again, there's a different, the medians are quoted 16 versus 3 months, hazard ratio 0.54. So that would strike me to the question, if you're going to redo this trial, wouldn't that be the population to do it in? Because if that turned out to be real, then that's a big deal.
Well, they're obviously showing their cards here by saying that. I don't like a lot of editorializing in these presentations, and certainly not on the conclusion slide. Whose opinion is it that that's profound? Why don't we just say an effect is seen in the subgroup of PD-L1 negative tumors, and leave it to sort of the reader to say? But I think you're right. I think that's sort of the insight into where they're thinking they might enrich this.
Yeah. So, I mean, I guess that's probably everything to say on that, wasn't it?
Yeah.
So maybe we should, did you say Checkmate 238 next?
Yeah.
Okay. So
shall I just put my feet up and let you have at this?
Let me have what?
Let you have at this. I'll put my feet up, and this is all you.
Oh, all right. Well, I don't know about that. So Paolo Mascietto presented this in one of the melanoma sessions. I think it was a poster to start off with, actually, and then it got upgraded into an oral presentation somewhere along the line. Am I allowed to say that or not?
Well, since you asked me about how come I didn't present S1801, maybe I can ask you, how does that happen? Changes.
I don't know. No, I don't know.
You know exactly how that happens.
No, I don't.
Yes, you do.
I don't know.
Guys, let's just say it out loud. Shall we say it out loud?
I don't know. Should we?
ESMO does not want to walk around with data that ends up in NEJM relegated to a poster.
Yeah, I don't think anyone would want to walk around with that, actually.
So you guys had submitted it and realized, oh, don't throw your hands up, Mr. Senior Author. But it's true, if it's going to get published in NEJM, then it really shouldn't be buried amongst the posters.
Any case. So final, comma.
Should we cut that part?
I don't know. Final, comma, 9-year. This is, I'm looking at the slides, results from Checkmate 238, which we're familiar with, obviously, because it's been presented and published a lot of times over the years. So Paolo did this presentation at ESMO. I don't know. I mean, I think we can cut to the chase fairly quickly here, which is to say that I think it's confirmed what we knew already. RFS, DMFS, no OS difference. A few other things were presented. I think in many ways the most controversial, which is the time of day. Maybe we just sort of pin that and come back to it in a sec. Editorial, I don't know if you've read it yet or not, in NEJM from Jed Walchok and Paul Chapman. I mean, I'd actually, I'm not sure I necessarily completely agree with what they were saying, actually, which I think I'm allowed to say, but I would recommend, and I've actually recommended already this week to our trainees that they read that, because I think it is food for thought, and I'm not really going to say anything else about it, because I think I'd suggest people actually have a look at that if they haven't already. still seeing a few late relapses as well, which is something you and I have definitely talked about before in the podcasts. And maybe it's just worth me saying something about that again. And again, this is something I've talked about this in clinic this afternoon with the fellows, that if you're following up people with stage 2 and stage 3 melanoma, and you don't have a marker of whether the treatment worked or not, which you don't with adjuvant by definition, then you're going to have late relapses, potentially because of the natural history of the disease in people who are refractory to the adjuvant treatment. And so there is an issue there, I think, to bear in mind, which is different from metastatic, that we do need to think carefully about how long and how we should follow up. I'm not saying there's a right answer either. It's largely evidence-free, but I think it's food for thought in clinic when we're thinking about how we follow up the patients, is what really I'm going to say there with a wrap. Are you going to try and force me to be prescriptive?
No, it just makes me smile because you and I did a podcast before this podcast. Before MM1, we did a podcast for Medscape, and you were banging the drum on this kind of stuff, which is like, how long do you follow patients? And, we shouldn't forget that there are some late relapses. I would have liked to have seen, and maybe I didn't read it properly, but I would have liked to have seen if those late relapses were people who finished the full prescription of adjuvant therapy, including on the IPI arm, 3 years, or was it in people who stopped early because of toxicity or, fatigue of getting the infusions?
That is an excellent question, and I don't know the answer to it. But
that feels different, right? Or
yeah, absolutely.
In a way, it feels different, and in a way, it doesn't, because also 12 months of adjuvant therapy feels incredibly arbitrary.
Oh, yeah, as we've said, and I think that's an important point. But it does take 12 months for the Earth to revolve around the sun. So, I don't think that's a controversial comment either. So anyway, just to pick up a couple of other things, maybe, sorry about the horns in Chelsea, as it were. So this is longest minimum follow-up of a checkpoint inhibitor trial in adjuvant solid tumor setting. So that's worth saying, I think. And then there's all the time of day stuff. And I won't really dwell on this, but I'd encourage people who are interested to read the paper. Maybe this is a subject of a podcast in its own right in due course, because it's a little bit of a bugbear, I think, of mine and maybe of yours as well. Obviously, it's interesting. Obviously, it's potentially important as well. But the real question here is, do we have good evidence that time of day of administration of therapy is important or not? And I guess we have a little bit of data, not just in melanoma now, but for me, I don't think any of this is strong enough to say that we should be changing how we do things at the moment. So that's 5+ minutes of talking from me. So now it's your turn.
So I think the time of day question is problematic. And it's problematic because we as oncologists want to see a pattern in something like time of day. We want to believe that our immune system has a circadian rhythm to it whereby the timing of infusion might matter. But there's some real biology here that doesn't get uncovered in these analysis, which is, how does a drug that sits on its receptor and occupies the receptor after the first infusion, how does then calculating if the majority of infusions are given morning or night even matter when that first infusion did a lot of the blocking? Half-life of these drugs. What a proper statistician will tell you, as Megan has told us in SWOG, all of these analyses fail to demonstrate proper accountability for all the biases, all the variables. If a patient lives farther away from their infusion center, it's just practically less likely that they're going to get a morning infusion. So is that, now we're calling that an immunological signal, or is that just a convenience thing? These patients who live farther from the infusion center get afternoon infusions, and you don't seem to account for any of that. When you start saying 75% of infusions were given in the morning or the afternoon or whatever, you're now already accounting for patients who got 75% of infusions. So there's a survival bias baked into that. You're not accounting for the patients who took 2 infusions and progressed. And what if those 2 infusions were morning infusions? So there's just some inherent biases that aren't accounted for when you look at all of these time of day things. And so I think we will probably try to bring this up at conferences and or in a publication just to sort of carefully think it through. Also, we have to be careful we have to be careful really rationalizing what we think the biology here is.
Yeah, all agreed. So watch this space. And you said if you asked a proper statistician, what do you think would happen if you asked an improper statistician?
So I'm kind of an improper statistician, right? I like statistics, I like numbers, but I'm obviously the wrong person to talk with authority on this. So I just think if you ask an improper statistician, they do analyses that will find signals where there are not signals.
That's a good answer, isn't it? All right, excellent. So next thing I think we thought we would do is the safe stock trial. Am I right?
All you have a lot of feelings about this.
Do I? I don't really know. Anyway, so this is from the Netherlands, presented in the same oral session Monday morning as the neoadjuvant studies, memory serves correctly. Early discontinuation of anti-PD-1 therapy upon achieving a complete or partial response in patients with metastatic melanoma. So that's the top line, basically. So what's the background? Well, I think we sort of know de facto that the quote-unquote standard of care for metastatic disease is a maximum of 2 years of treatment. That's sort of largely derived from Keynote 006, which we've talked about before. I think beyond that, and the fact that we stop for progressive disease or toxicity, I don't think you can really say too much more. And so really the question is whether stopping anti-PD-1 monotherapy, importantly, is safe in people who've got a confirmed response. So I guess I must have missed this at the time, but kudos, because this was designed at the ESMO, AACR, ECHO, EORTC methods on clinical trials workshop. You have a US equivalent, I think, as well, don't you? 2017. I went to that. Not in 2017. Yeah, I went in 2005. Actually, that's
2005.
Yeah, I'm pretty old.
What the F were you designing back then?
Neoadjuvant trial of Sutent in kidney cancer.
Source.
No, neoadjuvant. Neoadjuvant.
What would that be?
We never really ended up doing it with Sutent. We did it with everolimus instead, and bit of a long story short. So the clinical aspects of that actually didn't really work out, but that's the trial in which we got into this whole intratumor heterogeneity thing.
Cool.
It was cool, but if you read the paper, the patients got everolimus in that trial, and that was an iteration. And actually, Tim Eisen was the person who was kind of mentoring me for that as well. So small world, hey. Anyway, so that's good, isn't it? That's where the trial was designed. I think standard inclusion criteria, not a randomized trial. So basically what happened was that across the Netherlands, people who were willing to go into the trial and have treatment discontinued at first response basically were eligible for the study. So it's a fairly simple design. And maybe just to sort of cut to the chase, primary endpoint rate of ongoing response at 24 months from the start of treatment. And then a few different secondary endpoints. 200 patients, 2019 to 2023. And again, the primary endpoint ongoing response at 2 years basically was met. And that was 81.8% of patients with a median follow-up of about 54 months, a decent amount of follow-up. For me, the sort of the most interesting thing here is the people who had progressive disease. So, and I said this when we were listening to the presentation. So you're picking out the people who are doing well already by definition. The median amount of treatment was about 6 months of treatment, 24 weeks, something like that. And so remember, there were 200 patients. So 33 of the 200, so that's easy to work out the math there, 16.5%, had progressive disease within 24 months. And 9 of the 33 were diagnosed with new brain metastases. And that's over 25% of the 9. So that's for me, that's a sort of descriptive statistic of what happened. So my comments really would be that this wasn't a randomized trial. It was effectively compared with historical controls. Kudos to our colleagues in the Netherlands for doing this trial and the fact it got designed at that workshop. And as they say, I'm on their conclusion slides now, this is the first completed prospective trial to evaluate the safety of a shorter duration of anti-PD-1 treatment. They say that early treatment discontinuation was non-inferior. And the bit I guess I had a few comments on, results, this is the final bullet point, results of this trial indicate that early stop, in bold, of anti-PD-1 is safe, in bold again, in patients with a confirmed CR or PR. I absolutely think that is a conversation to have with patients in clinic, because if you've got someone in clinic and you say we've got a single arm trial, that you've had a response, we can stop treatment, I think they need to understand that the potential consequences of stopping treatment as per this trial is the rate of progression that I've quoted already and the development of new brain metastases. That's one thing. Of course, that could have happened anyway if the patients had carried on treatment, but that's the whole question here, isn't it? Because it wasn't randomized. And the other thing that we would have, and this is a reimbursement issue in the UK, is that once you stop treatment, you can't start it again as well. So if we were to try to implement this type of strategy in clinic, we would lose access to the treatment, because obviously the whole question is for the people who progress, can you put them back on treatment and re-induce response? And we don't have those data from this trial. So do you think that was fair, balanced, or was it harsh?
No, I think that's fair. You're saying, like, you like the data, but if you had to implement it in the real world, the conversation is harder than that.
Yeah. And what would you do as well? I mean, you're on treatment, you've responded. By definition, you won't have had toxicity already. Most of the patients probably have almost no toxicity. So we're carrying on treatment, it's working.
I don't know if I agree with that. I think some of my best responders have had a ton of toxicity and they go into complete response, but they have a lot of toxicity to show for it.
But the point is that's different. I'm just saying in this type of scenario where you've got people who are on treatment, so by definition they can't have had toxicity already because you'd have stopped it already. The treatment's giving them a CR or a PR. You're saying, oh, well, we could stop or we could carry on. They might say, well, look, this treatment's worked really well. I haven't had, by definition, bad side effects. I'd like to carry on, please. That's the point I was making.
How did I miss that? I don't get it. How is that different than the patient who has tox after cycle 2 and you're still carrying on? You're managing, you're carrying on.
No, but I'm just sort of saying for this patient group, anti-PD-1 monotherapy,
that's what this was PD-1 mono?
Yeah.
Oh, I missed that part. Sorry. Sorry. Somehow I thought this was based off with Ipi-Nivo.
No. It's anti-PD-1 monotherapy.
Well, that's its own.
Yeah, i.e. a well-tolerated treatment, and the patients may even feel better having been on the treatment because they have, they've responded right in terms of their metastasis. I'm just saying it might not, at least the patients that come to my clinic, this might not be an easy sell if you wanted to do it. But again, the trial wasn't randomized, so for me, it doesn't change practice. Is what I'm really saying.
And what was the degree of inferiority, the statistical alpha they were willing to?
Oh, no, that's a really difficult question, and there are a lot of slides, so now I'm going to have to go back and look. You
can maybe
tell a joke or something.
We can fact check it if we need. I think this idea of saying it's non-inferior to stop rather than continue for a trial of that size just doesn't come across sound to me. And so I'd be curious what that degree of non-inferiority was. And if you say the non-inferiority degree was 15%, I ain't sure we as oncologists think that's the same. Meaning, somebody could recur at a 15% greater rate, and we would say that's not inferior. I don't think that's how we would feel that.
Yeah, so I'm on the statistical plan now. I managed to find it while you were talking. And it says study would be positive. You'll understand this because you're a proper statistician. If the one-sided 95% confidence interval would be greater than 29%.
One more time, say it one more time.
Positive if the one-sided 95% CI would be greater than 29%. So one-sided greater than 29%.
I'm not sure I understand that.
Okay, so maybe we need to consult with a more proper
one-sided I
statistician.
get.
Yeah.
Greater than 29%. I'll look at it and maybe I'll say something relevant in the fact check. I don't know if I totally...
Not sure I do either, but I wouldn't.
We're not going to do a fact check. Let me scratch that because now you found the level of significance, so we're not going to. I don't know that weight sways with me. It would be positive if the one-sided confidence interval was greater than 29%. The confidence interval is just that. It's an interval. So how can we have a...
And also, I mean, it's historical control. So, I mean, if you see what I mean. So I think there's a kind of a, various caveats.
How big the study was?
It was 200 patients.
Yeah. I don't think this gives me the level of confidence. In the US, of course, I have the freedom of stopping therapy and then reinitiating it, but I would really drill down on that math that you said that, look, 16.5% are progressing, and then a portion of those are having brain mets as a site of progression. What I would like to see then is longer follow-up from this safe stop in the CRs so that we eventually know patterns of progression in the CRs, and particularly the CRs that stopped, right?
Yeah, I mean, the CR is going to do really well. We know that. But yeah, it's an important point.
That we do know they're going to do really well. And I want to know in the patients who stopped. In the patients who stopped in CR, because if you do think they're going to do really well and that's fine, then it sounds like you've already bought into this idea of stopping them, as opposed to they do really well because they took 2 years of treatment.
Yeah, absolutely. Sort of almost feels like a microcosm of neoadjuvant in a sense. You do something, you assess response. In this case, it scans, and then you try and figure out if people need more treatment afterwards or not. But anyway. All right, so that's safe stop. Now we're on 38 minutes.
Okay, we have 2 more to do. We're going to do them really fast. The one is the STAMP trial, EA6174. This is adjuvant pembrolizumab versus placebo, or versus observation, I think, for Merkel cell carcinoma. And the bottom line here, kudos to the cooperative group in the US for doing a study like this. Brian Gassman had originally designed this, and then Jan Maynard took it over and presented it. And this study really mirrored what ADMEC-O showed, Jürgen Becker's group in Europe, with the adjuvant nivolumab for Merkel cell, which is there's a signal here that may be, again, washed out by a group of patients who are either not recurring or maybe need more therapy. So essentially, they had a positive signal for distant metastasis-free survival of adjuvant pembro over observation. They did not seem to have a signal with recurrence-free survival. And so there's a couple of things here. If you look at those curves for recurrence-free survival, they kind of come apart, but then they start to come back together later. And of course, as Megan has taught us, like, hazard ratios account for all of that. They account for the beginning of a curve, the middle part of a curve, and the later part of a curve. So as the thing starts to come back together, the hazard ratio is thinking about all of that. And so to have a non-significant hazard ratio, if you will, or a non-impressive hazard ratio, it may be that these patients need more. What's so funny?
You've anthropomorphized hazard ratios.
Did I?
Yeah, the hazard ratio is thinking about that. That's great, actually. It's really thinking about the different parts of the curve. No, carry on. Curves.
This is about to go off the rails very quickly. Okay, but very quickly, this is just to say, if curves separate and come back together, then that might speak to a group of patients who need more than a year of adjuvant therapy, right? And so, there might be a group of patients who didn't need any adjuvant therapy watering this down. There may be a group of patients who would benefit from more than a year of therapy. Who are those patients? We might need some molecular signal to figure that out. So good job to the cooperative group for presenting this. It should end up in guidelines, adjuvant pembrolizumab to be considered for Merkel cell, just like adjuvant nivolumab probably should be considered, but it still leaves us in clinic really probably trying to parse out who should get it. Do we give this therapy to everybody if there's no strong RFS benefit, et cetera? Then the last study maybe to talk about very quickly, another rare cancer population, uveal melanoma, IMA 203. This is Anzu-cel. This is a TCR-based T-cell therapy against PRAME, HLA restricted, presentation of PRAME, autologous T-cells that are transduced with a T-cell receptor that recognizes this HLA PRAME complex. And we presented a cohort of 16 patients with uveal melanoma who received this. It's median third-line therapy for these patients. So they had received prior therapy. Everybody had received some prior liver-directed therapy. A good portion had received prior systemic therapy, including tebentafusp, including PRAME-directed bispecific type therapy. One patient had received that. So I think the takeaway and the reason we're sort of paying attention to this space is of all 16 patients had a reduction in their target lesion burden. The official objective response rate right now, or maybe we'll call it an overall response rate right now, is 66%. Disease control rate, so stable disease or response lasting at least 6 weeks, is in the 80%. But just to see a waterfall plot in uveal melanoma where everybody's ticking down, that's really impressive. And it is, median third line therapy. You can say what you want. We obviously pick patients very carefully for clinical trials, but that also speaks to not losing the signal here. If you are careful about picking patients and, even though they've been previously treated, and you can get this kind of response, it's great. We showed a case of a patient who'd received prior PRAME-specific, it's bispecific therapy, so PRAME-directed bispecific therapy, also HLA restricted, and that patient was on that prior PRAME therapy only a few months, had essentially stable disease as their best response, then got 7.9 billion of these PRAME-specific TCR T-cells, and had a partial response. They have 2 target liver lesions. One is completely gone away. It's completely resolved. And the other one is continuing to shrink. So basically it's an ongoing partial response. And that tells us something very interesting here. Prior PRAME therapy does not preclude you from getting a response to this PRAME-directed therapy. So as an escape mechanism, tumors can obviously downregulate PRAME expression. But at least in this one particular case, it didn't seem to be the issue. So, this will be confirmed in a phase 2. This is exciting future direction for uveal melanoma.
Yeah, really exciting. Congratulations again. It's fantastic.
Thank you. Thank you. I think I neglected to tell you congratulations on your NEJM paper, Checkmate 238. And I mean, it's also a big one, so we shouldn't forget that.
Thank you as well.
Thanks.
Thank you.